Okay, so I have few cases, and it will be like a rapid fire case. I will show the snippet of the case and I'll have my. So next, please, Ravindra. Next slide, Ravindra. Okay. So this is the first case. 50. He has a periampullary carcinoma. Had patient did not receive any adjuvant therapy. 5 years later, patient a loco-regional relapse, which he underwent cyberknife, and 2-3 years later, again last year during the pandemic, that is when I saw him first. He had which were not amenable to any loco-regional therapy, loco-regional systemic treatment. So we did 8 rounds of Folfox. Last one was in November. Patient had an excellent partial response. However, there was still unresectable disease, and we did consider some loco-regional therapy, but it was not very impressive. Patient's performance status is 0, except some peripheral neuropathy, which was because of oxaliplatin. We did NGS, and that's the report in front of you. It was MSS, the TMB was low, and there are several other molecular alterations. The first one, which I think so we will want to discuss, is the ATM. So that's the case, and I will start with Dr. Ahmed. Next, please. Ahmed. Next slide, Ravindra. So Dr. Ahmed would like to you take the first 2 questions. How often do you order broad NGS for periamp, and like what's there in periamp tumors? What are you trying to look for?
So Viraj, periampullary carcinoma, they do carry a good prognosis, and once they are metastatic, they behave almost like the pancreatic cancer. So once they are metastatic, I normally recommend broad-based testing up, you can say whenever they are. If it is at presentation, fair enough, we go ahead. And if it is on progression, then we go with the ampullary, with the NGS testing, but not for the routine periampullary carcinoma, which are manageable by resection.
No, I mean metastatic only. For metastatic.
Okay. So practically all of them, yeah.
Wow. Dr. Vinayak, what about you? What do you do in Bangalore for metastatic disease?
Sorry. In this subset of patients, I always prepare them from early, as soon as for the NGS one. And the second line, I would like to start some molecular dietary therapy for most of patients. But despite that, patients are very reluctant for the cost issues. So if possible, I get a HER2, that's it. But I think I have seen most of patients in this subset are ERP amplification than actually any of fish or other things. So either I do foundation one or I don't do any test. That's all it's happening.
So you do no other tests?
I can't hear.
You do either foundation one broad panel or don't do it at all. Is that what you're saying?
Yeah, that was my thing. But in this subset, for sure. In this subset, for sure.
Fair enough. Bhuvan, sure. Bhuvan, if I can come to you, what molecular alterations do you think in your mind? Or it's just a fishing expedition? Or you have some molecular alterations in your mind, which if you...
So especially in I think, so first of all, you're cracking up a little. Am I audible? So coming back to it, I think in a periamp, what I would want to... So in periamp, what I would want to kind of know in my head is, am I looking towards a duodenal kind of thing, or I'm going to looking towards a pancreatic kind of thing? So this is where I want to have I would want to employ IHC first of all, and then once I've had a clarity that I'm looking towards a pancreatic kind of thing, I possibly, most probably I'll probably end up having a KRAS kind of mutation or a ERBB3 kind of mutation. Or TP53. I think that's the more common mutation which you're looking towards in the pancreatic periamp. So if I am looking towards if I have my back against the wall, so generally I think if either be pancreatic or duodenal, I think first two lines are pretty sorted out. I think it's when you hit once you hit beyond the second line of palliative therapy, I think that's where the NGS would probably come in. And for me, then yes, it might become a bit of fishing expedition. But then if I can get a ERBB2 amplification, I can add something to it. I think that's more like it. Or I don't think there is anything else, because probably I kind of know that. Hello.
Yeah, this case was intestinal subtype. Just for your thing, and for intestinal
so exactly.
subtype.
So possibly if intestinal subtype, more time will end up looking towards a KRAS or a ERBB3 kind of mutation is where I come from. And I have not come across a targetable mutation in an intestinal periam. But yes, if something comes up, I'm up for it. Is what it is.
Okay, so Dr. Amol, the difficult question for you. So this periamp intestinal subtype patient had a DNA repair pathway alteration in form of ATM mutation. Would you be tempted to use PARP inhibitors in this case, or what would you manage this patient with? 5FU maintenance, or what would be your strategy?
I certainly will not use PARP maintenance, as there's no evidence at all. So if it is a desperate situation, then it's fine. But if you see this particular case, the onset of disease 2012, he's doing so well. So it's looks like disease biology is quite better than the other guys, the other disease as such. And now the response has come to FOLFOX. So certainly, I would just maintain patient on the capecitabine and just. But I don't think so. There's any data to support at this juncture, though that too not to my knowledge. But certainly I would not insist do the NGS, and if something comes here, I would generally look at for the disease biology how it is behaving, and possibly in
Right.
this particular case, I would not consider.
Fair point. Dr. Vamshi, just last question. This patient had a very reasonable biology of the disease. Would you consider PARP maintenance in this strategy? Suggest because we have DNA mismatch repair alteration. We have data for ovarian cancer. We have data in GI cancers building up. There are studies coming up. Would you do it?
No, not right now. I think the polo data was kind of definitive. You did not have an overall survival benefit. And whatever little PFS you're finding, I don't think that is strong enough that you start extrapolating that. And remember, polo was for pancreatic germline BRCA.
Right.
Here you have an ATM.
Right.
Now, we are not sure that the ATM behaves as good. Yes, it's the same pathway. And
Right.
in this case, you have a bunch of other mutations, other VOS. If you go back to your slide, you have plenty of FGFR, equivocal, FGF, equal. So many things were there.
Correct.
So when such a mixed picture is there, no, I won't be tempted.
Okay. So
I just have a small point here. So being it be intestinal, would you be tempted towards adding a VEGF somewhere as a part of maintenance? Add a bit of VEGF in the last line therapy and then continue with the VEGF maintenance. I think I'm just thinking aloud. That's something which.
So that was one that we considered 5FU Bevis. We did consider this. Dr. Abid, last point before I tell you what I did for the case. Would you do it or not, PARP inhibitor?
So, so the way I perceive the report and the clinical picture is little different here. If I'm just focusing on the chemotherapy options and if the FOLFOX works, fair enough. But if I see the profile, if you see the patient have MTAP loss as well as CDKN2A loss, which is a core deletion which is normally reported in mesothelioma, and has been well reported that these kind of cases do respond beautifully to pemetrexed and platinums. So the patient earlier had platinum, so had a good response. So we can assume that the patient is platinum sensitive. But just for the sake of discussion, that the another arm of chemotherapy can be opened up just by seeing the NGS report. And then second of all, if the patient is ATM altered, I would like to see the VAF here, the variant allele frequency. If the VAF is significantly high and representing the major tumor cells, then I would not use the PARP inhibitor as a maintenance, but maybe as a therapeutic option later on in my lines. In terms of using the VEGF, I think VEGF inhibitors can be added irrespective of the NGS report. What we see in this particular scenario, it will be synergistic. And also, if you see that the patient had a very good biology and very good, you can say, prognosis here, something is there which is basically underlying, especially the body own immune defense mechanism, and we should get the PDL1. And if the PDL1 is high, which is quite a possibility here, PARP with immunotherapy is also an option in the later lines. So you have multiple options coming out of this NGS report. Do you want to apply it now or later? There is a debate actually. But yeah, that's my take home on this. Yeah.
So yes, PDL1 we did. I forgot to mention it's 0. The CPS score is 0. So what we did is so this patient took opinion in Memorial, and they suggested same FIFU maintenance versus PARP maintenance as a trial. And this patient started on olaparib since November, and he progressed just last month in July. He had a partial response actually on olaparib. It was not just stable disease. Patient did well for about 8 months, and now he has progressed, and we're going for second line.
So what is the VAF on the ATM? Can I know that?
Can you go back, Ravindra? I remember.
Yeah.
It will be
backside. Does it mention?
It will be written in the detailed. It will be written in the detailed report. I think when the ATM will be written right below that, the VAF will be written. The detailed report will have it.
So again, we have to just if you have to see if there is a high VAF, then the response prediction it can be better. If it is a low VAF, it is possibly that you are hitting only few clones for that matter. Actually,
excellent point. Excellent point. All right, next case, Ravindra. Okay, so this is CA gallbladder, 62-year-old female, underwent surgery in 2017. Again, earlier stage, nevertheless had 6 months of adjuvant capecitabine based on BILCAP. And in just 1 year, patient had new liver lesions, which outright progressed on 3 of GEM-CIS. So there was a refractory disease to platinum, and patient's performance status was not great, PS2. But patient was very convinced that he wanted further treatment options. I was not going to offer them irinotecan. So we did an NGS, and this is the and the point about this report is, so everybody seen the report, because I'm going to the next slide.
Yes.
Yeah. Okay, next slide. So these are the questions which I want to from this report. Dr. Vinayak, how comfortable are you with the current available? We know there is a huge cost disparity, right? 20-30,000 versus 2 lakh rupees test. And what criteria do you use, whether you want to order an Indian test or a foreign test? Can you take on that, Dr. Vinayak?
Yeah, Viraj, I got to see the results of this molecular testing with gallbladder only. So we had patients who are lived more than 3-4 years. So we are very, at least I am keen on doing Foundation 1 or Claris. That's the two things I always do. But with a fish hunting, that is like doing all the tests using Indian panel, I'm a little skeptical. I'm not very got used to it. Not that I'm biased. The results were such that I did a report, it changed and other things. Recently, if it is a focused one like BRCA or HRD, I'm okay with Indian test. But this broad panel and TMB, I would prefer a Foundation 1 or a Claris.
So, Bhuvan, this patient has a subclonal alteration in IDH. What do you make of this? We know IDH is present in biliary tract cancers. What is this subclonal alteration, and would you be tempted for targeting this, or would want to confirm with a foundation-like test? How would you go about this?
So isolated dehydrogenase, I understand it is present in the GI malignancies. But then there are 2 points which you asked. What will I make out of it? Yes, I think that there will be a certain amount of alteration which is present, and I'll be inclined towards rechecking it if I intend to target. And for that, there are obviously 2-3 things: that the availability of the drug and it was to be. So I think if I am intending to use Evodacinib, I possibly might recheck it with a partner company or with an international panel. If I'm not planning to target it, I might not. Is where I come from.
Would you have ordered an Indian test just for sake of it, just like we did, or no?
So I think it's entirely, so let's be very clear. I think all of us, it's about the finances. There is nothing else to it. If somebody can afford a foundation, we probably will end up sending a foundation just because it's FDA approved and they have the data which we have collected by now is huge. However, if the finances is a concern, I obviously I do send an Indian panels and I have moderated a few panels of 4-base care also, and I felt that with they having a backing of RTREC and with the TMH backing, and the Illumina backing, I found them they they can be a good substitute for patients who can't afford a foundation.
We'll come with
if I'm
reports. I have some 4-base reports in the slides. We'll come to.
So I understand. So if you ask me, if will you send an initial panel? Yes, I would send an initial panel if the patient can't afford it. If a patient can't afford a foundation, that doesn't mean that there should be no foundation.
Great.
There should be no NGS.
Okay, Viraj, yes. I want to just share my experience here.
Yes, please.
So Indian labs are doing a good job. There is no doubt on it. Okay. And with time, they are getting better and better and almost with good quality results and all. So whatever comes in front of us, we should rely on it. But whatever is missed, we cannot comment on it. So it is very unusual to see all the important alterations to be wild type. And only a one subclonal alteration that is at a frequency of less than 1%. So something is missed. So if I were to ask, would you act on the IDH report? The answer is big no, because subclonal one. And is this report sufficient? The answer is again big no. We have missed probably so many things.
Great.
Had it, whatever I see in this report, I can count on it. But what I'm missing, I cannot just be sure about it.
I completely agree. So that is what I wanted to bring out. That what are my experiences? Many times the national tests often miss these alterations and we don't know what it is. Okay, next case. The next case is even interesting. There are two cases where I want to discuss one point. So the first one is the intrahepatic cholangiocarcinoma, had a nice response on GemCis for 6 months, and the patient has a partial response and wants further treatment. The NGS showed BRAF mutation, but it was a VUS. And in the second case, it is a G junction adenocarcinoma, HER2 negative MSS, FOLFOX 8 cycles progressed, paclitaxel ramucirumab 2 months progressed. Patient is still in good performance status, low volume disease, and patient wants further treatment. And this is another Indian lab, which again says BRCA VUS on some ROS VUS. So Dr. Amit, for you, when Indian labs report VUS, how confident are you saying that this is VUS and we should not target, or would you like to confirm it with the better panel?
Just come again. These are somatic alterations or germinal alterations?
Somatic. This is
somatic
discussion.
All right. So somatic alteration with VUS, I will not act on it at all. And top of it, if I can just clearly see that the BRAF alteration here is not a common alteration, so I am not worried at all. So I will not act on it. On the other hand, the BRCA alteration, which is showing the 31 of VAF, I think I would further investigate at a germline level. If it is there, then the rationale to use PARP inhibitor comes into sense. And if they categorically mention this is a pathogenic, I think again in a somatic panel I can still use it. But
so Dr. Ahmed, in this case, sorry to interrupt you, this is not pathogenic, this is VUS.
So that's what I'm saying, that BRCA report with a high VAF frequency should be further investigated. That's what I'm saying. Even if it is VUS.
Germline is negative. For
then we should not act on it.
So you would not go and do a foundation test to confirm whether this is likely pathogenic, or you would agree that this
foundation does not change the annotation of these alterations into VUS because most of these people uses the same databases across. So it is not that you will get the advantage of doing a foundation on top of it. On the contrary, you may find a new alteration that is missed by this particular report, but you may not find a change in the connotation of this particular alteration here.
So Dr. Vamshi, have you had any single experience where the Indian lab has suggested VUS and when you tested in the international lab, they have said it is pathogenic? Have you had a single experience? Any of my panelists?
So, Viraj, I think you're focusing too much on this Indian and international, to be very honest. I kind of agree with Dr. Amit that, just because the Indians are not bad. See, the problem is not that they're detecting the wrong mutation or they're detecting things not seen. The challenge is in the back end, when they're bioinformatics, you see that they have a larger database to play with. So they're able to tell you if something is not a VUS or something is more pathogenic. Because Indian labs generally don't have access to a bigger lab of which markers are there. So beyond that, I think we are focusing too much on this difference between Indian and Western. I don't think that's such a big difference. Like Dr. Amit says,
there is no difference.
Yes, no, I won't say there's no difference, but at the same time, I think they're okay. I think we should not discourage or just discount any report which comes to us and say, no, this Indian. Let's
I do a lot of Indian testing, Dr. Bam.
Yeah, I understand. Yeah,
I'm just saying.
So can I come in with a small point? So yes. My point is, see, eventually, as Dr. Amit said, the libraries are same. If there is a reasonable lab, he's probably going to, the VUS is going to be cross-checked with the same library. And the second thing is, when we're looking at the SNPs, if I'm doing it with the Indian lab and there's a respected Indian lab, isn't it more likely that if the Indian lab will probably have that similar SNP picture as to the Indian population, then a foreign lab will have a. So I would want to get into Dr. Amit's opinion also on this is, if I'm looking towards the Indian population, isn't it more likely that the Indian lab will pick up the VUS or a pathogenic better than a foreign lab?
Yeah, I think Bhuvan, for germline, you are saying correct, but for somatic, it remains the same actually. Yeah. For germline, we prefer the Indian cohort to give the answer whether it is a true VUS versus any likely pathogenic alteration. But for somatic, it remains always the same, and the database is more of a somatic database, and which is across the globe same.
And in this, there's a APC gene which also has a VAF of 36%. Is it something which is, if you look at that, can that be more of a germline? Can they have a?
We did germline, and there is no alteration in either APC or any DNA mismatch pair. So purely, this was just VUS. Okay, the point is well made that Indian tests, if they suggest VUS, there is very less likelihood that they would turn pathogenic with an international test. Great point. Next slide, please, Ravindra. Next. Okay, so this case is 47 male, metastatic gallbladder, HER2 3+ on IHC, MSS by IHC. Gem cis plus trastuzumab for 8 cycles, 6 months, and then trastuzumab maintenance for 4 more months. So 10 months, excellent first-line therapy. And then CT scan shows progressive disease. Patient wanted further treatment. We had a repeat biopsy, and this is the NGS report. So Bhuvan, I'll come to you. What do you make out of this report?
So with a MSH6 mutation, which is a likely pathogenic, I obviously am excited when I look at it, and I obviously think of a MSI high kind of tumor, and I think it does fit into the profile of MSI high because one of the microsatellite is mutated. So I am obviously inclined towards using a immune checkpoint inhibitor.
Despite IHC showing MSS.
So again, I think yes. Despite showing
Dr. Amol, I know you had a paper on gallbladder and you said very little to no MMR deficiency or MSI high in your series of 50 patients. What do you make out of this report?
So, though my friends from Delhi and North India, they say that MSI, once in a while, they get few patients. But now everybody agrees that it is less than 1% in our patient profile. So it is not that common. I am still continuing with the MSI testing, but I feel when you say GB, so there are many GB, it's not 1 GB. So there may be a GB which is just at the confluence. So you are treating the GB, but it may be intrahepatic cholangio or extrahepatic cholangio. So
no, this is GB. This is GB.
I know, but many a times when you go ahead with the GB, there are a lot of things. So in our series also, we are continuing the job. But till date, I must have tested around 110 patients, but somehow I yet to get a MSI high disease. Though, but people are saying that they get in between. So recently, Prashant Mehta conveyed me that after a long time he got MSI high, MSI on ISC, it was positive.
Mm.
So there are patients, there is no doubt about that. They do get, and people have treated with the Pembro, Nivo, or Pembro plus chemotherapy.
Correct.
And
But would you consider this MSH6 likely pathogenic variant and stamp this as MSI high?
No, I would not, because ISC is not getting concurred with your NGS report.
Vinayak,
And,
great.
I just want to make a point here is
Yes.
about the ERBB amplification.
Mm.
So what
I'll come to that. I'll come to that. I'll come to that. So first I wanted to discuss this MSI thing.
Yeah.
Vinayak, what do you get this when you have MSS on IHC and NGS comes up with this such a report?
Yeah, I've seen that there is a discordance between the IHC and even PCR. They do most of them PCR. So I have not got any case in NGS which has shown MSH positive and IHC is discordant. We have few patients who are PCR positive for MMR, so we have started immunotherapy for them.
What would you do in this case? Would you give IO or not?
So
short answer.
Just in the context, you have to tell it, because clearly there's a progression on trastuzumab.
Yes.
I would never, I mean, like for ERB amplification, I would not go for a MAB, or I would prefer either some TKI or TDM like drug apart from trastuzumab. So I want to address it. Otherwise, so
no IO, no checkpoint inhibitors.
I would check hyperinteract is worth trying because it's focus disease and we need to have a different mode. So I would try.
Dr. Vamshi.
See, here for me, when I read this report, it remains a HER2-driven cancer.
Yes.
Only thing is that TP53 has come in. Now, TP53 coming in, it kind of negates most of your other things now, which will happen. This is an end line of mutation.
Does it negate the checkpoint also?
Which one?
Checkpoint blockade.
Checkpoint blockade, see, HER2 positive tumors don't really respond well to checkpoint inhibitor. I take the point Dr. Bhuvan made that MSH6 is there, so let's try. But personally, with the MSS, I wouldn't really jump the gun. It is the expression that matters for me. I would actually put him on, again, I agree with Vinayak, either TDM1 or a lapatinib kind of thing. One thing which I have seen that you add any platinum, that seems to work in patients who have a TP53 mutation. So that is probably something else I would think of. Otherwise, TDM1 is what I would consider here.
So, Dr. Amit, final word for you. Would you target the HER2 or go for checkpoint blockade in this case?
So, again, if you see that the patient progressed on trastuzumab within 4 months, and the explanation comes here that
10 months.
10 months. So, initially the patient was on GemCis with TATs and then maintenance 4 months actually.
Correct.
So it reflects that the progression happened on a single agent Herceptin within 4 months. And the explanation comes here that the patient have TSC1 and TSC2 mutation, which is the activation, which leads to the activation of the PIK3CA pathway. And we have the resistance mechanism below the HER2 new what we are seeing here actually. So whatever said and done, if you go ahead with the TDM1, you may see response. But if you go alone with the MAB or TKI against HER2, you may find early failures. That is one point. On the other hand, regarding the MSH6 and the discrepancy, what you have seen in the IHC, again, I will go back and refer to the VAF here. If the VAF is high, the discrepancy has to be investigated by MSI, by PCR to just see whether we truly dealing with MSI high or not. If the VAF is low, then you may end up having MSH6 loss in only few cells, which will not be picked up by the IHC. So that will give me more clarity what I'm dealing with. In terms of the IO therapy, TP53 alone as a biomarker has not been established for response to IO therapy. And none of the biomarkers here will give me a clue that the IO therapy will work. So I will not go with IO therapy at all unless I'm very confirmed that this is MSI high.
Great. So this patient went on TDM1, and I was very sure that this patient is going to progress. And I also told Dr. Vineet Gupta that I want to enroll him for NHER2. But when I scanned him, CT scanned him after 4 rounds, to my surprise, he had a partial response. So now I'm not putting him on NHER2, I'm just continuing TDM1. So that is the fate of this patient. Okay, next, last case before we move on to the next session, last case. Right. This is again very interesting. 37-year-old female, metastatic gallbladder with Krukenberg. HER2 was negative, MSS on IHC. GEMCIS 3 cycles, right progression. The ovarian lesions doubled in size. So because of the symptomatic disease, we had to debulk her ovaries. And then she became very well. She has just little peritoneal disease and gallbladder mass. Her PS is 0. And patients wants further treatment. And this is the NGS report. Bhuvan, this is the report from 4base. What do you make out of this report? Would you use this report for targeting?
So this appears to be L858R mutation, is it? That's what it is showing, right?
Yes.
So yeah, so it's a mutation which is there, and the lack of the data. How many lines have she has missed GEMCIS? After that, there is so she has only missed GEMCIS, right?
But she progressed right on GEMCIS. She had no response.
So I think it's worth a try. Is what I. So let's start it. Can we do a chemo plus EGFR TKI together in this?
I don't know. I don't treat lung cancer, but Vinayak, let me ask Vinayak.
So
I
think EGFR with the for chemotherapy.
I think we sometimes forget the erlotinib does work in GB and it is approved for that.
Yes.
Use erlotinib, and this is the first disease where combination with chemotherapy was used before also, along with I think when it was used. So I think I would prefer to use erlotinib. The problem with erlotinib is short PFS benefit we get compared to newer drugs, but I would comfortably use erlotinib. It's not a issue because there's not much about.
Yeah. So I would recommend here to use the gefitinib or erlotinib. And there are 20% response rate, and I think if you get those patients and dig out it, these are kind of patients who are this therapy.
Dr. Amit, would you target this?
No. Before you go, Dr. Amit, I think VAF is. I'm sure Dr. Amit will say VAF, and I really think you should look at the VAF in this, because if the VAF is high, you probably should give EGFR. But I'm dying to listen to what.
Yeah. So I think there is. So even if the VAF is low in this situation, it is worth to go with chemo and TKI actually. So even if these clones, if they are low in number, they are the one which will be the trickiest to handle. So you have to address these clones with the TKI, and definitely the other wild type clones has to be handled by the chemotherapy. So combination what Bhuvan has suggested is the right choice here, I guess.
Okay, Dr. Vamshi, last point.
Okay, tell me one second. So at what VAF would you think you can do the TKI
alone?
Yes.
I would have.
At what VAF?
I would have, in a somatic alteration, any VAF more than 20 or 30 in that range gives me a lot of confidence this is a dominant clone, and it will work. So because normally when you do a somatic analysis, the other allele is a wild type. So practically you are dealing with only 50% of the allele, and then you have normal cells along with your tumor content. Exactly. Then your drops further down. So practically 25% plus minus 5 or 10 here gives you a confidence that majority of the cells are having EGFR alterations, and you should be confident to have response.
Okay. Dr. Vamshi, before I tell what I did, what would you do?
I would also agree with everybody. I would use some form of a TKI with this kind of a report.
I called you for this case, if you remember.
Yes, you did. I remember that. And you asked me about it. So I don't remember what I answered to you, actually, unfortunately. I would actually continue with the gefitinib. I would be tempted to add one more chemotherapy to it just because I don't know what I'm dealing with. I would probably add a paclitaxel and gefitinib for this.
Okay. So
no hard data, but that's what I would do.
So what I did is I put her on gefitinib alone. I asked you about this.
Yeah.
And in 2 months, her CA99 increased, doubled. So then I told her, then again I called you and you said, why not try osimertinib? So then she's on osimertinib, and to my surprise, she's on for 4 months osimertinib, CA99 just going down, down, down. And I think so she is doing very well on Tagrisso.
It's only 4 months, Viraj.
Well, for gallbladder, 4 months is very good.
No, but then have you looked at why is she responding to osimertinib? Because
have no
there is
clue.
no.
I think sometimes no, that initially tumor marker will be high of starting effective treatment. Sometimes we tend to look tumor marker very abruptly.
Well, I did for 2 months, Vinag. It was not that I checked in
It
50.
will be there always. There will be the kind of some flare will be there. It's effective treatment actually. That's what it means. So I would always take initial high before before imaging confirmation. I would never change. That's my input. I haven't been proven right for most of times. Just
Okay.
for TKIs, not for chemotherapy.
Okay, great. So that's about it. I thank you all my
I
panelists.
think
Yes, Bhuvan.
before can I just ask? Can I just one small thing? So Dr. Amit is here. So when you look at these MSI by IHC, why do you have these both IHC? Never be a single IHC which will be missing. I have tried reading about it. I just couldn't find the right answer to my satisfaction. It'll be either
So
be MSI,
whenever you have,
MLH1,
whenever you
MSH,
have,
PMS.
Yeah.
We generally have it in
Yeah.
pair.
Yeah. So the answer here is whenever you see MSI loss, 4 markers, what you do, MLH1 and PMS2 go in hand. If PMS2 is lost, MLH1 will be lost, and MLH1 is lost, PMS2 will be also lost. And then similarly, MSH2 and MSH6. If out of 4, if you only find one loss, then you could ask the lab to repeat the test, because that's a skeptical report actually. So I won't rely on that report. So it has to be
So
always
why is
in
that? Is
pair.
what I want.
So the
Why is
reason
that?
being,
Is what I want.
so when they make heterodimer, the stability of the protein is intact. Otherwise, the protein gets degraded very soon by ubiquitination and proteasomal degradation. That is the process. So that is the stability of the protein actually. Yeah.
That's the stability of the testing marker. That's what you
No.
Because
Stability of the protein inside the cell. So production remains the intact. That is a cytosolic production. But all these biomarkers are actionable in the nucleus. So before they go into the nucleus, they have to heterodimerize. And if they don't heterodimerize, they are degraded by the cytosolic enzymes.
and you can have a single marker loss in NGS rather. That will be a genetic loss.
Answer is yes.
Okay.
And you can
There'll
also
be a genetic loss and this will be a protein loss.
Yes, even if you have a genetic loss in one marker, it will be reflected in the loss of protein in 2 markers, because the other pattern will also get lost.
Okay.
All right. Thank you. Thank you all my
Thank you
panelists.
so
We
much.
can continue our discussion on the chat. We'll move on to the next session. Thank you once again, all my panelists. It was wonderful discussion.